So this is a question from Henriette. My question is, why do I have heart disease? My parents don't, and my son does. Now, this is a very simple sounding question with probably a very complicated
Mhm.
answer to it. Now, I will add a little one more thing to it because I have arrhythmogenic cardiomyopathy, but I'm the only one in my family who has it. So it's also something that I've been very just stunned about. Like, why am I the only one? So, yeah, why do some people in a family develop heart disease and others not?
Yes. So maybe I'll start with the answer to
Mm-hmm.
that question. I think, first of all, we have to realize that not all cardiac disease is genetic, of course. We know that there is also a significant group that's more related to lifestyle factors.
Mm.
But the distinction between those two is mainly made by the age at which it presents. If you look in the older population, there the major cause of heart disease will be problems with the coronary arteries, and there, of course, lifestyle factors are very important.
Yeah.
But if you go to the younger people, let's say below age 55, then we know that more than 80% of these heart diseases do have a genetic component to it. So there,
Okay.
the picture is completely different. It's not because of lifestyle factors, or often you will not notice that there is any abnormal lifestyle factors, but it's mostly determined by a genetic alteration. So you can look at it as a mistake in the architecture of the heart, either being structural or in the electric circuits that are present in the heart. And then within that big group of genetically determined heart diseases, we can distinguish also many different conditions. And most of them will have what we call an autosomal dominant mode of inheritance. What does that mean? Autosomal means it's unrelated to the sex, so both males and females can have it.
Yeah.
And dominant means that it is sufficient to have a genetic alteration in one of the two copies that we have of each gene. Yeah, so we call that a mutation or a pathogenic variation. Nowadays is used more often. And that alteration will lead to an altered protein, either in quantity or in quality, and those proteins do have an important function in the heart, either being a structural molecule and building up the heart muscle, or being important in the conduction. We call these most of the time ion channels, where they have variation leads to abnormal or less present protein in the heart.
Mm-hmm.
Um, for some genetic variants, we do know that they are sufficient to cause the disease. So you only need that genetic variant to lead to a disease. But for other genetic variants, we consider them more as a kind of predisposition that makes
Like a
you more
vulnerability?
prone to, yes, like a vulnerability, exactly, to heart disease.
Right.
And the one that you were mentioning, arrhythmogenic cardiomyopathy, is a very typical example of that.
Mm.
That we know that most of the time you need the genetic variation that's needed to create the vulnerability, but you need additional acquired factors on top of that. And that could be,
Mm.
for example, in athletes, extreme exercise,
Right. So there needs to be an
or substance
environmental
abuse.
component.
Exactly,
Yeah.
exactly.
Yeah.
We do not always know what that factor is, but sometimes we do know and we can identify it. And that explains also some of the variability within a family. So it
Mm.
can be that you inherited the genetic vulnerability, but if you don't encounter the specific triggers or the specific environmental factors that provoke the disease, then you will not develop it or develop it much later than somebody else in the family. So that is how we can explain that within the family there is variability in the symptoms and in the way the disease is presenting itself. In genetics, we call that penetrance. It means the chance that you will develop the disease when you have the genetic variation, and that's variable for different diseases. And for some diseases, the penetrance is very high, but for others, it's quite low.
What are actually some other triggers that could trigger the vulnerability in the gene?
We do know that alcohol in itself can be a specific one. It's estimated that alcohol in itself is toxic, but if you have a genetic variation on top of that, it's more likely that you will develop the cardiac disease. Some medications, we also know that they can provoke disease. A typical example of that is long QT syndrome and Brugada syndrome, where there is a whole list of medications that if you have a genetic predisposition and you take a specific medication on top of that, at that time you will develop the arrhythmias.
Sometimes it's strenuous exercise in athletes, as Bart already mentioned. Sometimes it's fever. So for instance, in Brugada syndrome, there are these very specific genotypes or mutations that we know are temperature sensitive. So that means that they will not, or almost the risk of developing an arrhythmia based on this mutation is lower at normal temperatures, but when the patient gets ill and develops a fever and at high temperature, the risk for arrhythmias increases. So there are many of these factors. Sometimes the genetic predisposition, so the genetic vulnerability, is not based upon one gene, but sometimes there are multiple genetic defects at the same time in the same person that also increases the risk for this for the manifestation of the disease. And we do see these families where we have generations where there's nobody that has any symptoms, that doesn't have any cardiac abnormality, or at least detectable abnormality. And then suddenly there's one person that is affected and that displays the abnormality, the cardiac disease, and also the symptoms, and the risk for arrhythmias that can lead to sudden cardiac death. It's actually often the case.
So I think the variability of presentation can be an explanation of the story that was presented. Another explanation is that sometimes genetic variations occur for the first time. So for example, in the case that you just described, it's possible that the patient has developed a new genetic alteration. When you make a sperm and an egg, you need to copy 3 billion letters, and nature makes mistakes.
Which is a mutation then?
Where that mistake is. Yes, exactly, or just a variation.
Okay.
And then, of course, once you have it, you can pass it on to your son. And a genetic variation always has to start somewhere, and it can be inherited, but it can also be what we call a de novo. So it means it happens for the first time, and that happened then during the making of the sperm or the egg cell.
Okay, and what about emotional stress? Is that something that could also trigger?
Yeah, so stress in itself is a state of, whether it is emotional or physical, is a state of hyperadrenergic tone. And we know that elevated adrenaline tone can increase the risk for arrhythmias. And of course, in a normal patient with a normal heart, usually this doesn't, this will not cause any problem. But in patients that already have an electrically lesser stable heart, in some of these patients, this can really lead to arrhythmias. For instance, in patients with CPVT or in certain types of long QT syndrome, if there's a very high stress burden, either physically or emotionally, sometimes this can lead to arrhythmias, which in normal patients this shouldn't be the case.